Okay. So, welcome back. Now we're going to talk about the third module again. What we've covered is the normal scalars. We covered pulmonary mechanics. Now we're going to talk about our patient-ventilator interaction. And then the last one, we're going to talk about, what our priorities are, how we're going to manipulate the vent. All right? So this one is very important. I'm going to just quickly review. I know you always like review. But remember, the first was the normal scalars. Normal scalars. All right? So if I tell you to draw them, you should know how to draw them. Okay? Let's say, pressure control, volume control. Hopefully you took some time, and you can just kind of do this quickly. All right? If you can't do this quickly, it's okay. Keep going, but just practice these. All right? Same thing. This one has no peep. Which you can always set a peep to 0. Sorry, I should have drawn this one first, all right? It's always good to draw the independent ones, which are this and this, all right? All right, then we talked about the pulmonary mechanics, the equation of motion, all right? Which is the pressure equals volume plus flow times resistance, plus volume over compliance, plus PEEP. And here's where we'll talk, just to remember, this could be your muscles or the vent, all right? And so now we're going to start moving out of the stage where it's all the vents, and we're going to be, talking about what happens when the patient's starting to use their muscles, and because we're going to be dealing with a patient-ventilator interaction. Again, when you're dealing with static compliance, when you're trying to figure out the driving pressure, you're trying to figure out, lung mechanics, we typically say static compliance, which is compliance at the state of no flow. So to make this easier, you essentially have this, and even if you just remember this vital relationship that, pressure equals volume over compliance, this will help you to understand what's going on with your lungs on the vent, all right? All right, back to a patient-ventilator interaction, all right? And this is extremely, extremely important, all right? Just always remember that there are always 2 ventilators, all right? The fancy one that we set, and then the one deep in the patient's mind. And that one is always much more sophisticated, than the one we manipulate with knobs, all right? And so you can start to think, one question that you always want to ask is the patient's respiratory drive intact? Is the patient's mental ventilator working? Why might it not be working? Well, predominantly, especially with a lot of these COVID patients that seem to have, at least we don't know that they have, an incorrect respiratory drive, is the drugs we give them. All right, so we give them drugs to suppress their own ventilator. That's what we say when we say we need to sedate them. We are saying that we want to suppress their ventilator so that our ventilator does, all the work, or more work. But if people have head injuries, all right, a lot of things can mess up one's innate ventilator. If people are encephalopathic, you often find that they have irregular breathing patterns. All of these things change one's own mental ventilator, but just remember that it's there, all right? So now that you know the normal scalars, let's say your patient is now waking up. It's time in these COVID patients, let's say we got them through the first whatever days, week, it seems like it's a long time, but we want to now have a patient awake. And why do we want that? Well, we'll talk about priorities, but you can't keep someone down forever. Their diaphragms will weaken, and you want them to essentially work out their diaphragm. And so you've decided that, at least at this point, we are done sacrificing, the patient's, sleep-wake cycle and diaphragmatic weakness and everything like that. We finished sacrificing that because we hope that they got through the major portion of the disease, or whatever happened that made us sacrifice that is now clearing up, all right? So we know what the normal scalars look like, all right? And I'm going to draw the normal scalars here. So this will be pressure control. And so I'm not drawing any PEEP on these patients. All right, there's no PEEP. And this is volume control. okay? And so let's just look at one flow curve for the sake of argument. We'll look at volume control. All right. So essentially, there's kind of what we're talking about when we talk patient-ventilator interaction. We're really now talking about desynchrony, and we want to, when someone says, "Are they desynchronous?" People now, if you know the normal scalars, you can start to understand what desynchrony means, because the normal scalars won't look normal. All right, because the patient is using some of their musculature, or in some way. Is desynchronous with the vent, and they're causing pressure differences and flow differences. All right, and so in general there are 4 different parts of the breath. All right, in which one can have desynchrony, and this is not so important, but I'll name it just in case you hear it. All right, and so let's take here. So first, this is the trigger. So you can have trigger desynchrony. We didn't talk about it, but on a pressure curve, you should usually see a little blip, and this is the patient, if the patient is triggering, and that's them, triggering the vent. All right, so they have to trigger a breath if they are awake and if they are triggering. All right, and usually on a vent you'll see that as a white line or a purple line depending on the vent. I'm sure it could be any color. All right, but you can have trigger desynchrony. All right, this is inspiration. All right, so you can have an inspiration desynchrony. All right, right here, when it goes from inspiration to expiration, it's called cycling. So you can have a cycling desynchrony. Cycling. And then you can have expiration. Expiratory desynchrony, all right? All right, so you can have desynchrony in all these areas. We're not going to go through all of them because every mode you have different synchronies. But really, what you want to do is when you see a waveform that doesn't look right, now that you know what looks right, and you see a patient especially, so always look at the patient. When you're dealing with a patient-ventilator interaction, you can't really do it unless you're looking at a patient as well, all right? Because you want your patient to look comfortable, all right? If you see that they're, belly breathing, or, which is, thoraco-abdominal dissociation, that is not good. And so you have to look at your patient, look at the waveforms, and try to figure out what is going on in the relationship between these 2 ventilators, all right? So for example, on pressure, again, let's say we have volume control, and this generally often will look the same. But let's say you have a patient, you see this. Now this might be subtle, but if I ask you, volume control, what's wrong? You know now that this should look like that. So the question is, what is happening there? This doesn't look normal. This would be the normal. So what's happening there? And then you can start to try to figure out. You can look at your patient, look at what's going on, and then you'll see what's happening is that the patient right here must be exerting a negative pressure, negative inspiratory force, which is pulling the pressure down. And so really this is work that the patient's doing. And this is called, flow starvation. Okay. Now, if your patient looks comfortable and it's a little bit like that, you might say that's okay. But you want to recognize the relationship. You'll see on vents this, all right? Often, now we'll say it's pressure control, but you'll see, let's give the patient a little peep, like real life. This is a common one encountered, all right? And what often this will look like is all right? And if I ask you, this is pressure control now, you know, what's abnormal about this? Now, you know, if you know the normal scalars, you should be able to look at this and say, you know, this is abnormal. So then think, what is going on here? All right. Well, what's going on here is you have a breath that's in the pattern of the breath you want, and then all of a sudden you get another breath without any expiration. All right. This is called double triggering. This is a cycling synchrony. All right. And typically what's happening, if you look at your patient, is that they're exerting, exerting a negative inspiratory force, or they're doing some work, and at the end of the breath, rather than, you know, going into a passive exhalation, they're still inspiring, which is triggering the vents to think that they need another breath, and they're actually getting 2 breaths. All right. And then if you look at their expiration, you know, their expiration volume will be larger than normal, all right? Because even though you set the patient for 6 cc's per kilogram, you know, which is basically that, you know, on this breath they got 12 cc's per kilogram. So, you know, these are important because, you know, the whole idea behind ARDSNet is that you wanted, you know, low tidal volume ventilation. And so if someone is, you know, double triggering every breath or every other breath or every third breath, you know, you can't really say that they are in a low tidal volume approach. All right. You know, so we can take another thing, and all this is really, this takes time and takes time to figure out what's going on with your patient. And you just want to think, you know, what's going on with their ventilator, what are they doing, and how are the 2 ventilators interacting. You know, let's say I have, you know, this. All right. And this is another. All right. You know, so I don't even have to label it. If I say, you know, what is this, a pressure mode or a volume node? You should be able to look at this and say, okay, this is obviously a pressure mode. All right. And what looks abnormal? Now that you're looking at the patient and they're awake, you know, so really they should be, you know, triggering here. So what's going on? Well, you know that it's supposed to look like this. All right, so what are they doing here? You know that normally, if the vent was doing all the work and the patient was paralyzed, the maximal inspiration should be here. All right, because that's the biggest pressure difference between the vent and your respiratory system, but you're seeing that it actually goes up a little bit. So in the same sense, this patient is creating a negative inspiratory force. Right here, the negative inspiratory force is actually making the flow increase even more. And again, this is work that the patient is doing. So this just takes time. The main thing is to understand what the normal scalars are, okay? Because then you can start working through what these abnormal scalars are. And so, I mean, I can give you something dramatic, all right? You know, where, you know, all of a sudden you're looking at the flow curve, you know, and you're seeing this, you know, this, often you'll see this. I mean, this is very dramatic, you know, in the flow curve. You know, you'll see this and you'll see a patient struggling, breathing, you know, 40 times a minute, 50 times a minute. They look terrible. And you know, the natural inclination is let's sedate them, which might be the right thing to do. But, you know, try to make sense of what's going on here. Well, you know, it's supposed to look like this, you know? And so really what the patient is doing a whole lot of work, all right? So they're actually using negative force to increase the flow higher, you know, and here, whereas this should be the highest, they're using expiratory force to push the flow higher, you know, and that's how it, you know, turns into essentially this. This is a patient that is not happy and is doing a tremendous amount of work despite being on the vents. All right, patients can still do a tremendous amount of work despite being on the vent. All right, same thing if you, sometimes you'll see this. so if I asked you what mode is this, you should be able to look at the flow curve and say this is a square waveform, this is volume control. What is abnormal? Well, obviously right here, right? This is supposed to go like this, and this is actually under the line. So, here there's no peep, but let's say that this actually was peep of 5. So this patient who is not paralyzed, who is now awake, is actually exerting significant negative inspiratory force and pulling the pressures down below the PEEP. All right, so this patient is doing a tremendous amount of work. Okay, and probably this patient, when you look at them, doesn't look too happy. And so really, it takes time, and you really got to spend some time at the bedside looking at the patient, looking at your waveforms, looking at the patient, and trying to figure out, what is the interaction between what's going on. Because the next section we'll talk about, our priorities and how to manipulate that interaction to what we want to achieve. All right, just a little primer of that. Let's say, what do you do with this patient? All right, you have this patient who looks like this, who's performing a tremendous amount of work. Well, you can say, listen, if maybe this patient wants higher volumes, and so they're just trying to get more force to get higher volumes. All right, let's say if you put them on CPAP, they in themselves they would breathe 900. All right, someone who's breathing 900 on CPAP, is probably not gonna. You're not going to be able to really easily fit them in a smaller volume box, and so you have to decide what's your priority. All right, let's say this person, let's say this was set for 400. All right, now if this patient has full-blown ARDS, real ARDS, or very, very bad pneumonia, and I think there's not even that much alveolar, not as much alveoli, to be involved with gas exchange, I may really want to stick to this. All right, in which case this patient probably needs to be sedated. All right, and so the benefit is you're avoiding volume trauma. All right, the downside is you're sedating a patient, increasing risk of delirium, messing up their sleep cycle. They're not doing as much work, and so you just have to figure out what your priorities are. For example, if this patient has no pulmonary disease, doesn't have ARDS, is intubated because of a subarachnoid, you may say, okay, rather I want to follow his mental status. His mental status may determine whether, he goes to the operating room or not for some conditions. You might say, forget it, I don't want to mess up his sleep-wake cycle, mess up his neurostatus, increase delirium in this neuro condition, and so I'm going to move the volume up to 900, because that I'm willing to my priority is to keep him neurologically intact and awake at the expense of injury, which potentially could be caused by volume. So that's a primer into the next section. We're going to talk about what are our priorities and how to sort of manipulate both ventilators.